Welcome back, everyone. This is Mike. We continue our discussion on management of diabetes in pregnancy, a clinical update. Today's topic is glycemic targets in pregnancy. Pregnancy in women with normal glucose metabolism is characterized by fasting levels of blood glucose that are lower than in the non-pregnant state. This is due to insulin-independent glucose uptake by the fetus and placenta, and by postprandial hyperglycemia and carbohydrate intolerance as a result of diabetogenic placental hormones. In patients with pre-existing diabetes, glycemic targets are usually achieved through a combination of insulin administration and medical nutrition therapy. Because glycemic targets in pregnancy are stricter than in non-pregnant individuals, it's important that women with diabetes eat consistent amounts of carbohydrates to match with insulin dosage and to avoid hyperglycemia or hypoglycemia. Referral to a registered dietitian is important in order to establish a food plan and insulin to carbohydrate ratio and to determine weight gain goals. Let's discuss insulin physiology. Early pregnancy is a time of enhanced insulin sensitivity, lower glucose levels, and lower insulin requirements in women with type 1 diabetes. The situation rapidly reverses as insulin resistance increases exponentially during the second and early third trimesters and levels off towards the end of the third trimester. In women with normal pancreatic function, insulin production is sufficient to meet the challenge of the physiological insulin resistance and to maintain normal glucose levels. However, in women with GDM or pre-existing diabetes, hyperglycemia occurs if treatment is not adjusted appropriately. Let's discuss glucose monitoring. Reflecting this physiology, fasting and postprandial monitoring of blood glucose is recommended to achieve metabolic control in pregnant women with diabetes. Preprandial testing is also recommended for women with pre-existing diabetes using insulin pumps or basal bolus therapy so that pre-meal rapid-acting insulin dosage can be adjusted. Postprandial monitoring is associated with better glycemic control and lower risk of preeclampsia. There are no adequately powered randomized trials comparing different fasting and post-meal glycemic targets in diabetes in pregnancy. Similar to the targets recommended by the American College of Obstetricians and Gynecologists, the American Diabetes Association recommended targets for women with type 1 or type 2 diabetes are as follows. First, fasting glucose of less than 95 milligrams per deciliter, 5.3 millimoles per liter, and either 1. A 1-hour postprandial of less than 140 milligrams per deciliter or 7.8 millimoles per liter, or a 2-hour postprandial of less than 120 milligrams per deciliter or 6.7 millimoles per liter. These values represent optimal control if they can be achieved safely. In practice, it may be challenging for women with type 1 diabetes to achieve these targets without hypoglycemia, particularly women with a history of recurrent hypoglycemia or hypoglycemic unawareness. If women cannot achieve these targets without significant hypoglycemia, the American Diabetic Association suggests less stringent levels based on clinical experience and individualization of care. Now let's discuss HbA1c in pregnancy. In studies of women without pre-existing diabetes, increasing A1c levels within the normal range is associated with adverse outcomes. In the hyperglycemia and adverse pregnancy outcome or HAPO study, increasing levels of glycemia were associated with worsening outcomes. Observational studies in pre-existing diabetes and pregnancy shows the lowest rates of adverse fetal outcomes in association with A1c of less than 6 to 6.5% or 42 to 48 millimoles per liter early in gestation. Now, clinical trials have not evaluated the risks and benefits of achieving these targets, and treatment goals should account for the risk of maternal hypoglycemia in setting an individualized target of less than 6% or 42 millimoles per liter to less than 70% or 53 millimoles per liter. Due to physiological increase in red blood cells turnover, A1c levels fall during normal pregnancy. Additionally, as A1c represents an integrated measure of glucose, it may not fully capture postprandial hyperglycemia, which drives macrosomia. Thus, although A1C may be useful, it should be used as a secondary measure of glycemic control in pregnancy after self-monitoring blood glucose. In the second and third trimesters, the A1C of less than 6% or 42 millimoles per mole has the lowest risk of large for gestational age infants, preterm delivery, and preeclampsia. Taking all of this into account, a target of less than 6% or 42 millimoles per mole is optimal during pregnancy if it can be achieved without significant hypoglycemia. The A1C target in a given patient should be achieved without hypoglycemia, which in addition to the usual adverse sequelae may increase the risk of low birth weight. Given the alteration in red blood cell kinetics during pregnancy and physiological changes in glycemic parameters, A1C levels may need to be monitored more frequently than usual. What are the recommendations to achieve glycemic targets in pregnancy? First, fasting and postprandial self-monitoring of blood glucose are recommended in both gestational diabetes mellitus and pre-existing diabetes in pregnancy to achieve glycemic control. Some women with pre-existing diabetes should also test blood glucose preprandially. 2. Due to increased red blood cell turnover, A1C is slightly lower in normal pregnancy than in normal non-pregnant women. Ideally, the A1C target in pregnancy is less than 6% or 42 millimoles per mole if this can be achieved without significant hypoglycemia, but the target may be relaxed to less than 7% or 53 millimoles per mole if necessary to prevent hypoglycemia. This ends our discussion on glycemic targets in pregnancy. See you next time when we discuss management of GDM.